What's nice about the case that we presented is, one, it's pretty typical. 65-year-old man presenting with intermediate risk disease, and yet this is a patient that's been treated by all 3 specialists. He's seen surgeons and underwent a radical prostatectomy. He was referred to medical oncology and was treated with abiraterone and recommended for radium-223. He's seen a radiation oncologist and gotten radium-223. This patient has already benefited from multidisciplinary coordinated care, if you will. In the future, he may benefit from other specialists as well. And just because he's had a radical prostatectomy doesn't mean there's not a role for the urologist. There absolutely is. These patients are at risk still for urinary issues and can benefit from continued follow-up and care. In addition, this patient may need other forms of radiation. An external beam radiation can be given either during or after radium-223. So yeah, this is a great example of how we toggle, if you will, from one therapy to another, how we involve different specialists, how we coordinate that care, and continue to work together to offer the patient everything we can to extend their survival. The most important thing when it comes to multidisciplinary collaboration is communication. Pick up the phone, call somebody, have clinic together so you overlap and you can share patients. Have tumor boards where you're discussing cases as a group. These are the things that bring us together as a field. And what's really important is to recognize that we're not fighting each other for cases. We're not fighting each other for control. We're fighting a cancer. And that's not the patient, that's their cancer. The patient is part of this, and they're part of our team. And communication with the patient, communication with each other, wise minds collectively, that collective experience, all of those things really go into optimizing care. And I still benefit from the collaborations, the communication, the tumor board discussion cases, the multidisciplinary clinic together with Robert Lee in radiation oncology in our group, with Judd Mao and Mike Ferrandino and Tom Polacic and other urologists in our group, with Andy Armstrong in our group in medical oncology, with Raj Gupta in radiology, with our pathologist, Jiao-Ji Wang and others. This is our multidisciplinary team. We have palliative care folks, we have social workers, we have nurses. This is the group effort. And that kind of shared communication back and forth is really what allows all that to happen, and why we continue to learn and improve our care together with each case that we share. Prostate cancer today is already much more complex than just 5 or 6 years ago. 5 or 6 years ago, we had docetaxel chemotherapy for metastatic patients, along with androgen deprivation therapy, and that's it. And the only real question was when you're going to use chemotherapy, or if you're going to use chemotherapy. That has changed now, and in just the last 5 or 6 years now, we have 6 treatment options to offer these patients, including second-line chemotherapy, including radium, including a couple of hormonal agents, Sipuleucel-T, bone anti-resorptive agents. And there's a whole new class of therapies coming that are going to be predicated on the biology of this disease, everything from DNA damage repair to neuroendocrine phenotypes and anaplastic, other drug targets involved in some of the genetics underlying the progression of this disease. How we incorporate that is going to be critical. If we continue to function treating patients with one drug at a time until that drug fails, we're setting these patients up for failure. The way we're going to go forward is by combining agents. And we're seeing this in some of the early clinical trials that were designed to do that. Some of the Stampede trials and the Charted trial demonstrated that chemotherapy with hormonal therapy really extended the survival on a much greater level than either of those therapies alone or in sequence. I think we're going to see the same thing when we start adding together other disparate mechanisms, including hormonal therapies with immunotherapy, with radiopharmaceuticals like radium, with other targeted biologies as well. So it's going to be really critical that we start thinking differently in terms of both our drug development, but even more importantly in our clinical practice, and how we begin to incorporate drugs that maybe were developed as monotherapies, but now really belong in concert together is critical. I think radium-223 and abiraterone is just one example. We can think of many others where patients could really benefit from the overlapping biology and non-overlapping toxicities of these mechanisms.